Kalra, welcome to today's session of the National Training Program of Pediatric Hematology Oncology chapter of IAP. We are getting back together after a hiatus of about 2 months because of PSYOP and the FOCON. So we were actually scared that a lot of us are going to forget to log in this. But nice to see that people are just, are there and they're looking forward to the session, right? So, Manas, few words from you.
Yeah, so just welcome back to the PHO Online Academics. And, we'll restart all the international and national programs again. I think the international program we have scheduled for January. So we'll get back to you with the plan for that very soon. And we'll continue with the monthly national online teaching program, which Shruti and Vasudev have been helping to organize. So we have a very interesting topic today, LCH, Unraveling the Mysteries. So, Shruti, over to you to take it forward. Thank you.
Thank you, Manas. So LCH is one disease, I believe we've got referrals from almost every department in the hospital. And it is crucial to diagnose the disease in time and also to stratify it accordingly so that no child is under or over treated with the diagnosis of LCH. And it's an evolving, era where a lot of new drugs and a lot of new, targeted agents are coming in. So probably all of us will be more knowledgeable about LCH after this session. So for the session today, we have three speakers. We have Dr. Sukanya S., who's a fellow at Institute of Child Health, Chennai. She will be presenting a variety of cases that they have seen in recent past. Then to discuss the diagnosis of LCH, we have Dr. Soumya Ranjan Malik, who's an additional professor in Department of Pathology, AIIMS, New Delhi. And finally, to talk about the evolution of treatment, how the treatment has evolved over last couple of decades, we have Dr. Ramya, who's a consultant pediatric hematology, oncology, and BMT at Apollo Hospitals, Chennai. So we would hand over to Suganya to start with her case presentation.
Yeah. Good evening, everyone. I hope I'm audible to you all.
Yes, dear, you're audible and your slides are visible.
Okay. Here we have case 1. He's a 3.5-year-old male child. His mother noticed a small swelling, which is of a size of a cherry in the right side of his forehead, which was present for 3 months. It was initially thought to be as a result of an unnoticed trauma. So he was treated in a local hospitals with multiple NSAIDs. Otherwise, child had no systemic symptoms, no pallor, no icterus. On local examination of right frontal region, the swelling was hard in consistency and it was not mobile. Other systemic examination was normal and no lymphadenopathy was noted. We proceeded with X-ray skull to know what kind of lesion it is. It showed a lytic lesion in right frontal region. We took a skeletal survey to find out if there are lytic lesions elsewhere in the body, but there was no lesions elsewhere in the body. MRI brain was taken to know if there is any intracranial extension and to know if the pituitary was normal. Pituitary and brain was normal, and there was only a lytic lesion with cortical thickening and spiculated periorbital reaction in right frontal bone, right lateral and superior orbital wall. Incision biopsy of the frontal region showed small round cells with irregular nuclei and prominent nucleoli. Background showed eosinophilic granules, and IHC showed CD1A positive, CD68 positive, and S100 positive. Other relevant investigations, everything were normal. Complete blood count was normal. LFT, RFT was normal. Urine osmolality, serum osmolality was within the normal limits. CT chest and CT abdomen was normal. He was diagnosed to have single system LCH. The lesion was inoperable as per neurosurgeon's opinion. So we started him on LCH induction therapy with steroid and vinblastine. At the end of induction 2, response assessment was done. It was stable, and we started him on LCH maintenance therapy, which ended on June 2023. Child was then asymptomatic for next 8 months. Later, he developed swelling, a new swelling in the left parieto-occipital region. PET-CT was done. It was a lytic lesion in the left parietal bone with associated soft tissue component and mild increased metabolic activity. Biopsy confirmed the findings of LCH. We gave the parents about the therapeutic options for the recurrence of LCH, whether chemo-based or non-chemo-based. Parents chose with non-chemo-based regimen, so we started him on Lendexa. After 6 cycles of Lendexa, PET-CT was repeated, which showed active disease better. Currently, child is doing well and he's on 10th cycle of lenalidomide. Shall we proceed with case 2, madam?
Yes, please.
He's a 2-year-old child with multiple swelling over scalp for 6 months. Swelling was also present in the right temporal region for 2 months, and history of bilateral ear discharge was present for 1 month. No history of prolonged fever, pallor, or icterus. On examination, he was found to have abdominal distension with liver palpable 3 cm below right costal region and spleen 2 cm below left costal margin. Local examination of right side of the face showed 3 cross 3 cm hard swelling in right temporal region, inferior and lateral to the right ear. CT brain showed 4 cross 1 cm lesion in the left parietal region and 4 cross 3 cm soft tissue lesion in right posterior auricular region. There was also destruction of the mastoid. Brain was otherwise normal, pituitary was normal. HRCT temporal bone also showed lytic lesion of the right mastoid extending to squamous and petrous part of the temporal bone. CT abdomen showed hepatosplenomegaly. Excision biopsy of the right temporal swelling showed features of morphological features of LCH with CD1A and S100 positive. CT chest also had features of lung LCH and other relevant investigations were normal. He was diagnosed to have multi-system LCH involving skin, lung, bone, liver, spleen with risk organ involvement. Treatment started with LCH induction 1 with steroid and vinblastine for 6 weeks. On mid-cycle of induction 2, child was found to have progressive disease in the form of massive hepatosplenomegaly and icterus. MRCP abdomen was done, which showed intrahepatic bile duct dilatation with hepatosplenomegaly. UJ showed features of DCLD in the form of grade 2 esophageal varices. We started him on propranolol. And we also escalated his treatment to salvage therapy with cytarabine. After 4 cycles of cytarabine, the child still had persistent jaundice and abdominal distension. Response assessment was done at that time, which showed active disease stable with elevated bilirubin levels 5.9 and 2.9. So we escalated the treatment to intermediate dose cytarabine. After 2 cycles of intermediate dose cytarabine, response assessment was done, which showed active disease better. So we continued the intermediate dose cytarabine for other 3 cycles, and currently he is on 3rd cycle and his last bilirubin was 2.7 and 1.4. Shall we proceed to the 3rd case, ma'am?
Yes, Suganya, thank you.
He is a 1-year-old male child who presented with bilateral ear discharge since 7 months of life. So for the same complaints, he had multiple ENT admissions for which he was treated with antibiotics. He also had scalp seborrhea 2 months back, for which he was advised clotrimazole by some local pediatricians. But due to persistence of symptoms, he came to a hospital. On examination, he had no fever, organomegaly, anemia, and jaundice. And due to this typical combination of seborrhea and otorrhea, we proceeded with skeletal survey to rule out LCH, which showed lytic lesion in the left parietal bone. Skin biopsy was done from his seborrheic lesion, which showed morphological features of LCH with CD1A, S100, CD68 positivity. MRI bone showed lytic lesion in the left parietal and left mastoid with hyperintensity in the left mastoid. CT chest and abdomen was normal, and other investigations were also normal. Bone marrow was normal. He was diagnosed to have multi-system LCH with CNS disc lesion and started on LCH induction therapy. At the end of 2 induction, whole body PET was taken to see the response. But it showed still metabolically active lytic lesion in the left temporal bone and left mastoid bone, with mild peribiliary hypodensity in segment 5 and 6 of the right lobe of the liver. Risk assessment showed only active disease worsening. So we escalated his treatment to cytarabine and vincristine-based therapy. Post 3 cycles, we repeated the PET, which showed decrease in the size of the soft tissue component and mastoid, and it was not extending intracranially. Previously, it was extending intracranially, and there was also reduction in the size and metabolic activity of the cervical nodes. Active disease was better, and so we are continuing him on the same line of management. Currently, he is in 5th cycle and he is doing well.
Thank you, Dr. Sukanya, for those cases. I think, a lot of times we think LCH is pretty easy to treat and a simple disease, but what you have shown, I think all of us would find it difficult and hard to treat, right? So I would next, move on to the next speaker. That's Dr. Soumya Ranjan Malik from AIMS, who will be talking to us about diagnosis of LCH.
Thank you, Dr. Shruti. Let me share my screen. Can you see my screen?
Yes, so we can see. Just put it on the slide. Yeah, done. Thank you.
Good evening, everyone. So I'm going to talk about the diagnosis of Langerhans histiocytosis. I'm sorry, I have a severe sore throat, so I apologize if my voice is low, but I try to speak loudly. So before going to the diagnosis, I hope everybody is aware of the classification systems. There are basically two classification systems people follow. One is the WHO classification, same described by the hematopoietic neoplasms. But what we found very more convenient is the histiocyte society classifications. So this histiocyte society classification is more of easy to memorize and easy to understand on the biology perspective. For the residents, if I came to know many residents are joining, you can just memorize like Mr. LCH, L group for the LCS, ECD, and ICH, then the xanthogranulomatous group for the C group, then R group, the rhodoidophen group, M group, all the malignant, and H group is the HLH group. So, like M, R, Mr. LCH. So, this is the most convenient classification and very easy to memorize also. So before the diagnosis, you must understand how we diagnose. Everybody knows this Langerhans and CD1A is the characteristics features. But these cells sometimes they normally also express. It is not abnormal expression of the Langerhans. So how they normally express? This very nice article in the pediatric pathology by this Ronald Jaffe, one of the pioneer in histiocytes. If you see this normal Langerhans, they are expressed in the liver sinusoid. Hello. Am I audible?
Yes.
Yeah, okay. So, and these Langerhans are normally present in the skin epidermis, but there are only few, and also in the sinusoids. So you will find these normal. So for the diagnosis, you need a lesional tissue rather than an enlarged lymph node. Yes, lymph node do involve, but the pattern will be different. So, but just by seeing a positivity of Langerhans, it doesn't make a diagnosis of LCH. So this is a very recent. I'll discuss few cases in between. I will try to make how we approach our cases at All India AIMS New Delhi. This very recent cases. There's multiple skin lesions in the adult. And when we receive the biopsy, it's a very peculiar pattern which shows a unremarkable epidermis. There are in the upper dermis and in the lower up to extending in the subcutaneous tissue. When you saw it shows very characteristics mixed inflammatory infiltrate which shows these neoplastic histiocytes admixed with the eosinophils. But it is absolutely negative for Langerhans. And if you see, these are the normal Langerhans pattern. So what I like to say here, so these are the normal cells which are resides in the skins, and if it is a neoplastic that comes to the dermis and try to proliferate, and these cells you can see this kind of finger-like kind of patterns, which is a normal distribution. When they became a clonal, they became neoplastic, they come down to the dermis and keep on proliferating. So this is not simply a case of a drug-induced inflammation where you find lots of eosinophils and mixed inflammatory infiltrates. Similarly, another case with a large inguinal node in an adult, if you see there this marked expansion of this paracortical zone and also these sinusoids, which shows again similar kind of inflammation. There are few eosinophils and many these histiocytes with abundant cytoplasm, and few of them show pigment. And if you see, these are Langerhans positive and CD1A positive. But if you see this characteristic pattern, this pathologist can identify this is called dermatopathic lymphadenitis. If there is any skin lesion and the patient keep on scratching, so this Langerhans cell they pick the pigments and come to the paracortical zones. So, and this is the normal in it's a very what called differential diagnosis of LCH if you find a only node. But if there is no clinical skin lesion, no bone lesion, so this is basically dermatopathic lymphadenitis. So I'll say LCH is a diagnosis of a clinico-pathological, or rather than only pathologist see some Langerhans or CD1A positive cells. So now come to the case. It is a 6-year-old male and a lytic skull lesion and multiple skin patches. So we received a skin biopsy from our pediatric department, where you can see the ulceration of the skin, and wherever the epidermis present, it is almost thinned out, and it is a mixed inflammatory infiltrate which comprises these eosinophils, and you can see this histiocyte. They're devoid of these finger-like processes, and they have the characteristics groups. You can see these coffee bean groups, and they are positive for CD1A Langerhans. So you need only very minimal stains to immunohistochemistry for diagnosis of a Langerhans cell histiocytosis. CD1A, S100 Langerhans, appropriate clinical context, appropriate cells, it's very well diagnosis of LCH. So in early lesions of LCH, you find eosinophils and neutrophils, but as the disease progress, so that might be you find more macrophages, fibrosis rather than this kind of inflammatory background. And this particular case, we also do almost all cases for the VRAF. So VRAF can be done by this Sanger sequencing and real-time PCR. So I'll prefer like to do a real-time PCR based approach rather than a Sanger sequencing, because Sanger sequencing needs more allele frequency to become positive. If you see this particular case, this GTG, you have 2 peaks here where T is replaced by A. So there is a heterozygous mutations in the V or a V600A. So this is characteristics, classical cases of LCH, very easy. So currently we are no more doing this Sanger sequencing because real-time PCR is easy to do and much more higher sensitivity, but Sanger may come negative sometimes. So let's another case. This is a 3-year-old female, cervical lymphadenopathy and bony lytic lesion. So this is a very tricky case. So we receive a true cut biopsy. So I'll request my clinical colleagues, it's better to give if possible, we understand the situation like doing a excisional biopsy versus a core biopsy, but excisional biopsy is much more preferable over a core biopsy. So there are multiple cores, and we see a mixed inflammatory infiltrate again, where we find these numerous eosinophils, histiocytes. They are all large. They are devoid of all these processes, and many of them have been groups also. But when we did Langerhans, there are patchy positivity, the similar kind of positivity which we saw in the previous one, like in the dermatopathic lymphadenitis. So then we did, so we are not sure, like a CD1A is patchy, Langerhans is patchy, whether to call, and there is no skin lesion. The problem is it's called skin lesion, and there is a doubtful lytic lesion also. They cannot do a biopsy from the lytic lesion. So in between, so the patient, when they came back after, then we discussed in our tumor board. So we have decided to do a rebiopsy for confirmation. So in the rebiopsy, the disease has progressed. If you see the previous one, it is much more like the node is almost gone, and we don't call it effaced architecture, but it's much more expanded to the previous one. And now we are finding some giant cells also. And similar feature. Again, these histiocytes are much more bigger, numerous histiocytes. There are giant cells. So it is now more obvious than probably we were dealing with a neoplastic lesion, but similar profile, few Langerhans positive cells and CD1A positive, very strongly positive. So we thought probably it is a neoplastic. Again, no skin lesion, no like a VRAF again comes negative by real-time PCR. So we referred to the case to Dr. Roland Jaffe. So they, after multiple discussion, they told it's not possible by snapshot, but probably LCH. So then another case I'll say is an 11-year-old male, absolutely no symptoms except inguinal, no skin lesion, no imaging normal, only a inguinal lymphadenopathy. And you see the node, it's almost expanded. These are the reactive follicles, expanded paracortical zones, also the sinuses. So paracortical zone can be expanded in dermatopathy, but this is an 11-year-old kid. We can expect a dermatopathic lymphadenitis in a farmer, in some other conditions, or any skin lesions. But this is only an 11-year-old kid. And it shows a numerous histiocyte, but no eosinophils at all. And the histiocytes, of course, these are not typical of a coffee bean nuclei, but there are numerous histiocytes, and they are diffusely positive for Langerhans. So this creates a problem whether to call only without a skin lesion and a what call a lytic bone lesion, only basis of a Langerhans positivity. Yes, it is much more than the which we expect normal. There also is the higher power Langerhans positive, CD1A positive. So we come and VRAF again comes negative in this case also. So we communicated to our clinician, so they thought they will be doing more investigation, they follow up, but the child never came back again to us. So these are the tricky cases to see whether it is to call these cases are LCH or not, because isolated nodal LCH is extremely rare without a skin or lytic bone lesion. One more stain we use normally in the last few years, the literature shows the cyclin D1 is diffusely positive in case of a neoplastic histiocytes compared to your normal histiocytes. But in these cases, it again comes a patchy. So we don't know actually what's going on. Probably a very aggressive dermatopathic lymphadenitis or cori LCS. We need to do a more thing. So and no more we are doing this. This is a classical book pictures. I have also taken from the book only. This is ultrastructure Bribeck granules. But now it is not required for the diagnosis to do a EM because Langerhans positivity is equivalent to having this Bribeck granules. But this is the classical one. Just for the so what should be the diagnostic criteria we use? So atypical histiocyte, they are generally large, round to oval shape with a coffee bean nuclei, and positive for CD1A, Langerhans, and S100. And this is not required. And how to identify? CD1A is a nuclear stem in the surface, and Langerhans is a cytoplasmic. So this is the IHC algorithm which you can use. If you see this algorithm, there are two closed DDs. Of course, rosette dominant disease, we see lots of emperipelosis, not much of a concern, but sometimes you find a very few emperipelosis those cases that might, but ECD, Erdem-Chester disease may create a problem sometimes. So to differentiate these two, you can use CD1A, Langerhans, and this ZBTB46. We don't use at our institute this strain, but 1A Langerhans is well enough. But to from a reactive versus a neoplastic histiocytes, you can use cyclin D1. And also for the ECD show more of a xanthogranulomatous inflammation and variable degree of fibrosis. Of course, LCH can also show sometimes fibrosis, but very later stage. Then you can use CD163, which is more diffusely positive in case of a ECD, but not in case of a LCH. And I'll recommend this. This is a very nice article again from the Gaurav Atal, which is very active in Histiocyte Society. This is more of a Histiocyte Society and few international consensus. So this is very nice what they are typically recommending. So if it is A, it means more than 95% conscious. B is around 75 to 94, and if 50 to 74. What is it? So biopsy of the lesional tissue. So what's again for the clinical colleagues, you have to do a lesional tissue, not a bone marrow, not the lymph node. If it is a skin, better to do a skin. If node is involved, then okay. Lesional tissue, even in the circumstance of highly suggestive clinical or imaging features, and establish BRAF any other MAP kinase pathway. I'll come again to this. And LCH should be considered in the presence of characteristics, clinical and radiological feature. Even histological feature is unequivocal. So I'm going back again to my case 3. If that patient has any skin bone lytic lesion, we could have called it as a LCH. But in the absence of clinical context, just by equivocal histopathology, we cannot call this. And one more thing, even if BRAF is wild type and high clinical suspicion and equivocal histological diagnosis, NGS should be done to find out other MAP ERK pathways things. So currently no role of routine bone marrow biopsy in the adult LCH. However, due to high prevalence of concomitant subsequent myeloid neoplasm, bone marrow biopsy can be done. All patients of LCH should undergo BRAF V600 mutational testing. Yes, IHC can be done, but IHC in Ventana works well. Other platform may be sometimes inconsistent. Better to do a mutational studies by real-time PCR. That's much more sensitive. So BRAF V600E wild type cases, next-gen sequencing should be undertaken to assess MAP ERK pathways. In the absence of sufficient tumor tissue, cell-free DNA can be used for the BRAF mutation. So what are the other mutations you are expecting in case of equivocal cases? In case of histopathology, you can have a MAP2K1 or a MAP3K1, ARAF, NRAS, and KRAS mutation. Then in collaboration with the clinical features, you can diagnose LCH. I hope this, and one more thing regarding the monitoring, there are many studies like literature in a research point of view only. They do BRAF by the circulating BRAF V600 mutation for therapeutic monitoring, but right now it is not recommended as per the consensus guideline for the clinical use. Thank you. I'll be happy to answer if any questions.
Thank you, Dr. Malik. We'll go ahead with our third talk, and at the end of all the 3 talks, we'll take questions from the audience.
Oh.
Thank you. So our next talk will be by Dr. Ramya, who will be talking to us about the treatment of Langerhans cell histiocytosis. Over to you.
Thank you. Yeah, thank you, Dr. Shruti and Vasu and Dr. Manas and Shripad Banavali, sir, for this opportunity. So I'll just take you through from the beginning what happened and why people decided to do research on LCH, and presently where we are in terms of treatment, and in India, what's happening, because there's a lot happening in India now with LCH as well, and more people interested in doing research on that. So this, as everything else in any field for that matter, things start by parents who wish to take their child to treatment and parents who wish to see their child treated. So be it immune deficiency or anything else, and more so for histiocytosis, it has, all the research has happened because parents have taken initiative to encourage doctors to come together and to do research. So this was way back, I think in 1980s, I think. And then that's when this little girl had LCH, and I think that there wasn't much, treatment that was available, especially for CNS LCH. And they went to Dr. Angio, Dr. D. Angio, who we know is a very big name in terms of histiocyte treatment and histiocytosis. And they decided that, we have to do something about it. So Dr. Angio is the one who got a lot of interested physicians and parents together. and they set up the Histiocytosis Association, and then they set up the Histiocyte Society. And truly, this society is something that runs by funding and by work which is done by foundations like the Nicholas Foundation. So this is Nicholas, who we have heard about, and he has sequelae of CNS LCH, and his family does a lot of funding for the Histiocyte Society, along with the family of the little girl that I showed earlier. So this is how the steps were taken. And when this group of people came together, they decided, let's do some studies on LCH. And that's where LCH1, the first trial of LCH1 of the Histiocyte Society, came about in 1991 to 95. That's when the trial happened. It was a randomized trial for the treatment of multisystem LCH. And the goal of this trial was to so the goal of this trial was to basically, the fact that steroid works in LCH or in any condition was known already, and patients were being given steroids, but the outcomes were not sustained, and then it was known that we need to add something else to sustain outcomes, because steroids alone was not enough. So on the background of high dose of methylpred, which was used earlier, they decided to check whether vinblastine works versus etoposide, and they recruited about 523 patients in this particular LCH1 trial. And what was found was, both as single drugs failed to provide any adequate disease control. You do need to combine them with the steroids. As a sustained steroids also over time, not just a high pulse dose of steroid. And what was found was there is definitely poor prognosis. That's when they started realizing the concept of risk organ, which is liver, lungs initially, but we'll come to where lungs stand today, and hematological system and spleen. So what was found from this, if you have any of these involved, they are known as risk organs, because these are the patients who don't respond well to the medicines. And the response at 6 weeks was found to be extremely crucial to determine outcome. Then subsequently came LCH2 trial, which went on from the 90s, I think 95 to 2000s, early 2000s, where they looked specifically at the addition of etoposide to the standard chemotherapy arm of vinblastine and prednisone. So by then, vinblastine plus steroids was determined as the standard of care, which is what we all of us use even today. And etoposide was added to the backbone of this, and to check if it does make a difference, especially for multisystem LCH. And 6-MP was added as a continuation therapy. So again, with data and with trials, it was found that LCH initially was thought to be not a malignant condition, as we know. Now we know it is a malignant condition, especially since we know about the BRAF mutation associated and the MAP kinase pathway associated with LCH. So initially, because it was thought of an inflammatory or a pre-malignant condition, there was more data which was available and studies which said that a short duration of therapy results in reactivation. So therefore, you need longer durations of therapy. So it was thought, let's add 6-MP to the prednisone and vinblastine arms for about 6 months. And what were the main findings of LCH2 was that they found that age less, and this was another point which they wanted to look at, is whether age less than 2 years made a huge difference in terms of outcome. So what was found is age less than 2 years per se by itself was not an independent prognostic marker. However, patients with the risk organ involvement had significant disease-related mortality, and this group required the therapy intensification, and certainly not everyone. So like we know now in ALLs, where people are trying to say, okay, let's de-escalate therapy in those who do well. Or in medulloblastoma, for example, we know that in Wnt pathway, they do better, so de-escalate therapy. It was found that the low-risk patients do better, even with slightly lower doses of therapy, and no need to toxify them with a lot of chemotherapy. The overall treatment duration was of 6 months. And they found in this trial per se, as compared to historical controls, they found that when you stop therapy at 6 months, the reactivation rates were higher at 44% as compared to historical trials as by the German group, etc., where 24% was the reactivation. And then came the LCH3 trial, which I will go a little bit into detail because this is what all of us, follow. Here, multi-system LCH, within that group itself, they decided we should have high risk and low risk grouping, depending on the amount of the RO involvement and the response to that. High risk stratum was made in such a way that you have vinblastine steroids and you add methotrexate upfront itself. And at the end of 6 weeks of initial induction, if there was persistent disease, further 6 more weeks of second reinduction was instituted as part of this therapy before we go on to continuation therapy. And in the low risk stratum, within the trial itself, there was a randomization between 6 months and 12 months, and which provides better sustained remission. So this was the what LCH3 is and what most of us are following. Now, before we go to the results, we'll go into over time and over studies, what have we found about the treatment of various types of LCH. So what has also been found is, we know that vinblastine steroids are the standard of care, but there's a lot of other drugs which work in LCH, and treatment can be modified based on how the child is responding. Vinblastine steroids would be the upfront treatment and standard of care for all of us, definitely. But having said that, there's a lot of evolution in terms of other drugs as well. So based on your child, like, Dr. Suganya said so nicely, those 3 different cases, different kinds of drugs work in different kind of LCH. So we should not be pedantic about only one particular protocol working. And especially considering the fact that LCH is a condition which, 1, requires a long sustained treatment, and 2, is associated with significant reactivations. There can be multiple lines of therapies which may work in the child at multiple points in time before we finally reach a stage where there's no further reactivation, hopefully. So as far as classification and risk stratification is concerned, mainly we have 4 groups: single system, multi-system with risk organ, 3 groups: single system, multi-system with risk organ involvement, and risk organ negative. Now, treatment decisions are based on the low risk organs are involved and whether LCH is unifocal, multifocal, or multi-system disease. So multi-system is defined as 2 or more systems which are involved, obviously multi-system, with risk organ. So now with time and after LCH2, lung per se as a risk organ was removed. It was pulmonary LCH is a different thing altogether, but lung as part of risk organ was removed. So risk organ involves liver, spleen, bone marrow. Without risk organ is obviously without involvement of these. Single system is where only one system is involved, single site or multiple sites. Single site is where you have one site, for example, skin, bone, lymph node. Multiple sites are mostly multifocal bone disease. So where you have multiple vertebra, humerus, femur, etc., everything is involved. Special site is skull-based lesions with intracranial extension or vertebral lesion with intraspinal soft tissue extension. And why this is important is because these can suddenly cause a lot of morbidity and mortality per se itself. So these are special sites. Pulmonary LCH is isolated lung involvement, also can be a presentation of LCH. We know CNS LCH, either you can have tumorous, mass lesions, or there's neurodegenerative disease, where there are 2 types, where you have LACI and LAX. LACI is where LCH associated abnormal CNS imaging, and LAX is LCH associated abnormal CNS symptoms. And these also determine treatment. Now, the treatment of low risk disease can be decided based on whether they are single system or multi system. So if we go to each, if there's isolated skin involvement, there is some recommendation to say observation can be done in pediatric patients who are completely asymptomatic, or to give therapy in those who are symptomatic. However, if you see this caveat here, patients with skin only involvement need to have complete staging, because 41% of them can have multi-system disease. So not to just leave them without follow-up or some sort of treatment. And careful clinical follow-up of these children is very important, because skin only LCH, because they can be associated with a lot of progression to high risk disease subsequently. The treatment options for symptomatic skin only LCH, just a second, can be either topical steroids, which can be given in these children,
Ma'am, your voice is not coming.
Yeah, I know. Sorry. I just needed a second. So the treatment options for symptomatic isolated skin lesions can be either topical steroids, but recurrence is known. So why I have put all this is because there's a lot of recommendations, or sometimes there's always a thought process whether we should do these or no. But finally, a lot of these children do recur. So if we are opting for these, which ideally we shouldn't, we would prefer to keep them on very close follow-up and finally go on for the vinblastine plus steroid combination. So topical steroids also have been shown to be effective. Oral methotrexate by itself, oral hydroxyurea, oral thalidomide or lenalidomide, and lenalidomide, as Dr. Suganya had mentioned, topical nitrogen mustard, although the data is not so much, and chemotherapy.
What is the cycling you wanted to?
So coming to skeletal involvement, this is decided based on single skull lesions of the frontal, parietal, or occipital region, or single lesions of any other bone. So curettage, again, I had one big argument with one of our orthopedic surgeons who said that curettage does work in single site lesions. Usually LCH, as we know, is a systemic disease because there is involvement of BRAF, etc., that we saw. However, when it comes to just single site bone lesion, which is other than the skull lesions, curettage with intralesional steroids can be done, but these children need to be on follow-up. However, we do not need complete excision, and excision of skull bones requiring grafting, etc., also is not recommended. So if you have, recently we've had a couple of kids like this who've been to the neurosurgeon. There was a not base of skull, I think it was more near the occipital bone, and it was excised by the surgeon more in terms of a biopsy, but it turned out to be LCH. And then we did a PET CT. It showed no residual disease at all. And so we've not started this child on any chemotherapy, however, keeping them on close follow-up. But skull lesions, which are in the mastoid, temporal, or orbital bones, these are the risk organs. So risk organs are mastoid, temporal, spheroid, all of these. And why are they called risk organs? Because there is an increased risk of developing diabetes insipidus, followed by further CNS involvement in these. So therefore, purpose of treating these children is to decrease the chance of developing diabetes insipidus and other long-term neurological problems. So I mentioned Nicholas, who is one of the families which supports Histiocyte Society. He has sequelae of CNS LCH, and he has a lot of trouble because of that. So that is why it's so important to recognize this. Now, the current treatment of CNS risk bone disease is 12 as per your multisystem disease, which we will come to. And this is the weekly vinblastine and prednisone, along with the continuation therapy. So this would involve the regular chemotherapy that we're giving children. Now, if there's a vertebral or femoral bone lesion alone, which can cause there's risk of collapse, certainly there was some thought about whether these if there is no soft tissue involvement, whether these children can be observed. However, again, need to keep on close follow-up, and especially if there is any soft tissue edema or involvement, they will need chemotherapy. Multifocal bone disease treatment is the usual standard vinblastine plus prednisone. Now, just a word on bisphosphonate therapy, because we know that bisphosphonates also work in these. There is data to say that pamidronate at 1 mg per kg per course, given at 4-week intervals for 6 cycles, has shown good resolution of skin and soft tissue lesions in children who are on follow-up, and zoledronic acid also after pamidronate, but pamidronate would be preferable. Having said that, this is not standard of care for upfront LCH. Upfront LCH would still be vinblastine and steroids. Now, CNS lesions can be of 2 types, either mass lesions in the cerebrum, cerebellum, choroid plexus, or they involve the hypothalamic pituitary axis, therefore resulting in diabetes insipidus and other endocrine. So here you would need drugs which cross the blood-brain barrier. Again, vinblastine steroids are the first line. However, there are other drugs like cytarabine, cladribine, which are sometimes more effective in CNS disease. So therefore, if you start a child on 6 weeks of vinblastine steroids, there isn't much improvement. Really, discussion needs to be made whether these children should be changed to the cytarabine or cladribine-based therapy. Now, clinical neurodegenerative syndrome, LCH, CND-LCH is a terminology. These are children where you have MRI changes of LCH. However, they don't have, they may not have a lot of symptomatology. They'll have these T2 flare lesions. And the reason why this is important to recognize is because here you may not be able to get a biopsy. It may be difficult to biopsy these lesions. So this is more of a radiological diagnosis. There's no specific optimal therapy for these. Earlier studies had said that not all LCH-related radiological changes need to be treated per se. However, if you treat them at a later stage, the incidence of permanent neurological sequelae was significantly high. So now the recommendation is keep on very close ongoing evaluation, do MRI screening, and start therapy early for these children before they reach the stage of neurodegeneration. Some of the drugs which work here are cytarabine with or without vincristine, BRAF inhibitors, and rituximab specifically, especially when they are refractory to upfront therapy. Now, high-risk multisystem LCH, the treatment is the vinblastine with steroids. However, mercaptopurine can be added for the continuation phase, especially if it's high-risk multisystem disease. Recurrent and refractory or progressive LCH, multiple protocols are available. Vinblastine plus steroid can be rechallenged in these children, especially if there has been a significant treatment-free interval. Vincristine, steroid, cytarabine, single agent cytarabine, cladribine, clofarabine are drugs which we know work in refractory disease. Cladribine plus cytarabine combination we know can be as toxic as an AML chemotherapy. So we need to be prepared with adequate supportive care when we treat these children. Now, this I would like to, it was good to see this, that these are no longer considered effective, because sometimes, like Dr. Shruti was mentioning, LCH children can present to anyone. They can present to a radiation oncologist, they can present to anyone, and certainly extensive surgery is not indicated. Radiation therapy is not indicated, except maybe if they present with a lot of intracranial disease or they have spine, cord compression, but these also usually respond to steroids. So refrain from, if radiation oncologists tend to, I have nothing against them, but if they tend to push for radiation therapy, steroid DEXA works very well. So we can start them on that and then subsequently monitor for response. So this is finally the LCH3 trial results, which which has been interim results which were published, which said that therapy prolongation improves outcome in multisystem LCH. So prolonging therapy decreased reactivations. The methotrexate arm, which was added as part of LCH3, did not show any specific benefit. So there isn't an upfront recommendation for methotrexate. So the results finally of the LCH3 were that the combination works best if it is given for 12 months, especially in high-risk disease. The lack of response in high-risk disease patients defines a small group who need more effective therapy. Patients with low risk also benefit from a 12-month therapy as compared to 6 months. So there is no debate about that. And so the 12-month versus 6 months, the reactivation rates were 37% with 12 months, and while they were 54% with 6 months of therapy. Methotrexate in high-risk disease did not show any specific benefit. However, addition of 6-MP in continuation can be added to your protocol. LCH4 is ongoing. They've basically divided into 7 stratums to look at what is the role of salvage therapy, stem cell transplant, second-line therapy, and these one by one the results are being discussed, but we don't have the results yet. Targeted therapy, I'll take just another 2-3 minutes on targeted therapy. So targeted therapy is not the new kid on the block, but it is something that is being discussed more and more because of the availability of these drugs now in India. So BRAF, so this we know is the pathway, as Dr. Malik also explained, the RAS pathway, MEK pathway, BRAF pathway. BRAF inhibitors of emirafinib, which has been approved for BRAF V600E mutated Erdheim-Chester disease, and dabrafenib is approved for BRAF V600E mutated LCH. MEK inhibitor is trametinib, which has been approved for pediatric LCH. Now, the dabrafenib and some recent actually report from Cincinnati Children's has found trametinib individually also to be very effective in multi-system LCH as well. Now, the difference between the two is that dabrafenib, as we mentioned, can work only if BRAF V600E is positive. However, trametinib, because it works in the downstream pathway, irrespective of the BRAF status, your trametinib can work. So therefore, if you are not looking for BRAF status, or irrespective of that, if you have a child where you want to start the targeted therapy, trametinib would be a good drug to consider. So this is just data which I wanted to share from a study which we had done. We presented this recently in the Histiocyte meeting. We looked prospectively in infants and children where we added trametinib either upfront or as a second-line therapy. It was given only for biopsy-proven LCH who were refractory to first-line therapy with steroids or vinblastine or had significant comorbidity. The dose which was used was which is a standard recommended dose. I mean, 0.015 milligram per kg. And because these are small babies and infants, we were able to give 1/4 or 1/3 of the tablet alternate days or half tablet alternate days for slightly older children. And we counsel families to say that a minimum of 2 years, they need to commit to this drug. Now, always the problem is about cost. So this is what we looked at in the study. So the out of the four children were recruited. Three of them were infants, 4, 6, and 7 months of age, and one of them was an older boy, 3 years old. They had all multi-system disease. One of them had progressive multifocal bone disease. And the response was complete metabolic response in all of them with no significant adverse effects. The infants have been on follow-up for this is actually earlier, now they're on longer follow-up, at least 12 to 15 to 18 months. The cost implications, one bottle of 60 tablets was sufficient for 4 months for all the children because we were giving either 1/4 tablet or half tablet. So that comes to 44,000 for 4 months, which comes to 11,000 per month. So if we can find funding in such a way that for 2 years we can get 44,000 for 4 months, it is something to consider. The problem, of course, with LCH, with trametinib is that we don't know when to stop. There is some data from Cincinnati group where they're saying that after 2 years you can stop and see. However, reactivations also are known, so that's something to keep in mind. But again, the concept is coming up to say that maybe LCH being the disease that it is, the inflammation may die down by itself. So eventually, hopefully, we should be able to come off medications in these children. But at the moment, we need commitment for at least 2 years. And lastly, to touch on the INPOC trials, this is the Lendex trial, which 7 centers were gracious enough to participate in. And we had 15 children in this trial. And the overall response rate in the lenalidomide and dexa patients was about 73%. Now, Dr. Suganya mentioned about their patient being on the 10th cycle of lenalidomide. So this is something that we found in the trial, that at 6 months, at 6 cycles, the responses were lower as compared to 9 cycles. Again, highlighting the fact how we need long sustained treatment for LCH. The future of LCH, of course, is bright in India, hopefully, because we have more INPOC multi-center trials. I know there's a trial that the Tata Group in Mumbai is doing where they are adding etoposide in those who don't have PET response. I wouldn't talk more about it because, I don't know more about it, but it's a trial which is ongoing, which is again cost effective, especially in India with patients with risk organ positive disease. And of course, we need to address the gaps and address early referral and diagnosis. Thank you. And thank you for my wonderful team and my mentor, Dr.
Thank you, Ramya, for that elaborative talk and taking us through the journey of LCH treatment. So I believe there are a couple of questions. One was about the cost of trametinib that you have answered already.
Yes.
There's a query by Dr. Vidhi. She wants to know if the drug is approved for pediatric.
Yeah, it is. It is approved. It is
Yes.
approved for pediatric LCH.
Right.
FDA.
And Dr. Suganya has asked if it is necessary to do BRAF mutation, but I believe that you have answered that you really don't need to do that. This is something that can be used in negative patients as well, right?
Yes, because it targets the downstream pathway. So
downstream pathway. Okay. While we wait for other questions, I think I can take the liberty of asking a couple of more questions. Dr. Soumya Ranjan, do you do NGS for all your patients with LCH, or do you recommend a subgroup of patients? Because NGS any day costs about 15 to 18,000. That would be the minimum range. So, if it's not available in house like you do it in AIMS, so what subgroup of
We are
patients would
not
you recommend it for?
okay. Regarding the NGS, we don't do routinely for patients because most of the case, as I told you, if it is appropriate clinical context, only 3 stains, 1A, 207, and CD100 is effective enough to diagnose. And then BRAF, B600 mutation will help you. Routinely, we are not doing at all at AIMS. So it's required where the high clinical suspicion, but unequivocal histopathology or IHC, and again BRAF is non-contributory. Those cases you should go for NGS to confirm the other pathways like RAS, RAF, or MAK21. So then only required. Otherwise, 90 to 95% cases you can diagnose by these 3 stains and also IHC as when required, imaging and BRAF. Only BRAF. Maybe 5% cases you require in ambiguous cases to do NGS.
Thank you. So, Ramya, Dr. Dhruti wants to know how many cycles of Lendexa would you give to a child who has a partial response after initial 6
Yeah.
cycles?
So that's what I said. So I think in the trial itself, we found that 9 cycles had more sustained response. So certainly partial response at the end of 6 cycles. I think a minimum of all patients, that's what we're hoping to do as the next part of the trial, is to do 9 cycles of Lendex for everyone, followed by probably maintenance with 6-MP. Something to discuss because or we could stop with 9 cycles, but yeah, probably at least 9 cycles you could give. And there are centers, I know Dr. Manas has given 12 cycles to a child, and as long as it is well tolerated and there is no significant side effect, there's no limit to 6 cycles, certainly if there is only partial response.
Right. So, Dr. Malik, would you like to take the next question, that if a patient is multi-system risk organ negative but has BRAF positive, so would you change? I mean, I know it's more of a clinical question, but do you recommend a higher treatment for this kind of positivity?
The clinical questions, I don't know.
Ramya,
Like if it is
over to you.
refractory, so maybe you can go for a what called this pathways, the targeted therapies. But sorry, I will be
I
silent on
agree
this
with you.
issue.
I
Yeah.
can
No,
direct that.
so I think I mean the histopath showing BRAF is shouldn't be the determinant for changing treatment. Add to it that it will be positive, and I think what percentage most patients with LCH, right? I mean,
BRAF is like BRAF positivity will give you a added advantages that you can add some point of time, but it doesn't require that you have to give it.
Absolutely.
It's according to your protocol. I think you should go ahead. So BRAF positivity doesn't necessarily that you have to give
Prognostic,
targeted
exactly. So it's not a prognostic marker, so you wouldn't change treatment based on that. You would change treatment only based on the response assessment with PET or whichever imaging that you would, if there is no response to the upfront therapy.
BRAF you can use for monitoring because people have used, but it is not again a mandatory thing to monitor through BRAF. Yes, people have used few trials and few research model as a part of research. They have shown that in a multi-system disease, BRAF can be used for the therapy monitoring. But again, it's not a mandatory right now at all.
Right. So, Ramya, is there any role of etoposide addition to vinblastine pred in high-risk multi-system?
So, as far as upfront standard of care therapy, it is not recommended as far as LCH3 is concerned. But in refractory disease or patients, who are not responding, so this is, I think, I don't know if anyone from Tata is there, but they are doing a trial where, because I interacted with them in the Histiocyte Society, they had a poster on this, that at the end of 6 weeks, if PET positivity is there, then I think they are adding etoposide to the vinblastine pred arm and keeping it in some maintenance as well to look for response so that these patients don't go on to become refractory. But per se, upfront, it is not recommended as yet, at least. And I think a role of indomethacin, Dr. Richa was asking. It would be similar to how pamidronate has a role in um, uh, LCH. Uh, Most likely not upfront, but if there is persistent disease or partial response despite others, then you could use it as maintenance therapy. Similar to even celecoxib, that way has a role as maintenance therapy in LCH. Patients who've taken a long time to respond, or you are expecting them to have reactivations. After completing your therapy, it's not wrong to keep them on this maintenance, and there is data for that as well. I mean, not just feeling. There is.
Yeah. So, Ramya, regarding MRI, so would you do MRI in all patients with LCH lytic lesions or only certain skull bones?
Only if it's CNS risk organ involvement. Otherwise, PET-CT is what we are using for most patients. Yeah.
Okay. And, we were talking of the treatment algorithm, right? So, multi-system, it's probably easy to decide, but the confusion comes when it is, if you can just reiterate single system, solitary lesion, when to treat, and single system, multifocal, what
So,
are the
as far as the LCH3 protocol is concerned, all irrespective have the 6 weeks of vinblastine with prednisone. At the end of 6 weeks, where if it is single system or multi-system risk organ negative or multifocal bone disease, for example, those are continued on if they are in remission, you would continue with the same vinblastine steroids at 3-weekly interval. But if it is risk organ involvement or if there is CNS risk organ disease, then they need to be put in the high risk category, and their addition of 6-MP is what is recommended as far as the LCH3 is concerned.
Right.
In
So this
maintenance.
similar question, only single bone clavicle involvement with no other organ involvement. Would curettage with steroid suffice, or you
Yeah,
would
parents will be anxious, and so will we be very anxious for recurrence. I mean, depends on your surgeon and what your tumor board has decided. If it is for any single bone, a single site bone involvement other than CNS risk organ or vertebra where it can cause cord compression, etc., there is a role for curettage with steroids and to keep them on close follow-up. I used to be very much against this, just not giving systemic therapy, curettage with intralesional steroids. And I was very scared whether we should, but we had a discussion in our team, and Dr. Revati and our orthopedic, everyone was there. And then we looked at data to say that these children need to be on close follow-up. However, there have been a good percentage where you would not have required systemic therapy, but to keep on follow-up and to inform them that if there is any recurrence, they will need vinblastine steroids. But the thing is that if they haven't received earlier any treatment, they should respond to vinblastine steroids. It's not like they'll become refractory and shouldn't. So it can be followed if your orthopedic and your other team members are okay with the follow-up with the patient.
And Ramya, your comment on lung LCH, Dr. Puni has inquired that, how do you monitor and what are the preferred treatment regimens?
I think imaging only, but if anyone else has anything more to add to it, as far as the protocols are concerned, it's the same protocols for a pulmonary LCH, and it is not considered a risk organ anymore, lung. Yeah, I think I wouldn't have more to say about it. If anyone else wants to comment on that.
Any comments from the audience regarding lung LCH, if you have had any experience treating lung LCH?
This is Dr. Warrior. I had a question.
Yes, sir.
Hello, Dr. Warrior, please go ahead.
How late can lung metastasis lesions come after treatment? Can it come much later in life?
I mean, lung LCH,
Yeah, because
sir,
some kids get cured, and years later can they get lung lesions?
yes, sir. I mean, late reactivations in LCH are known, right? And
Especially in the lung.
I don't know about whether specifically for lung, if anything is different. So honestly, I don't know about it, but reactivations are known to occur later. Whether
Okay.
there is a specific thing about lung, I'm sorry, I will have to look up. I'm not aware if there's anything specific to lung per se.
So, Ramya, which organ do you find most difficult to manage?
I mean, I think the CNS one would be
Yes.
because of the sequelae that they have, actually, more than anything else. And the vertebral bone ones, because they have a lot of pain. So the boy where I mentioned we had given trametinib, he had a lot of pain. He did respond very well initially. And then when he had the recurrence and progression, the pain came back. And definitely the CNS LCH, because they do tend to have sequelae, especially the intracranial risk organs.
So, Ramya,
And I think just to mention, sorry, about
no,
liver LCH, that I know that it's one of the most difficult ones to treat because I didn't mention that, sorry. Liver LCH, because they present with high bilirubin, liver failure, etc. And then their giving vinblastine steroids and other drugs becomes difficult. So I know that Dr. Deena and Vimal, all of them have done some studies on using cytarabine alone upfront and showing some response, getting them into remission. And they've had kids who've had liver transplant, etc. So liver LCH needs a more multidisciplinary discussion before planning treatment.
I think Dr. Karthik has suggested the pulmonary function test monitoring could be better if available and can be done by a child. Probably yes. What is the role of hematopoietic stem cell transplants? And
No, we haven't transplanted anyone with LCH so far. And but there is some data, especially in those who are refractory to multiple lines of therapy, multiple lines of all kinds of therapy if they've been used. But this data was pre-targeted therapy era. So now that we have targeted therapy, maybe the role of HSCT will go down even further because with trametinib.
so I just came
This,
across one
this is Dr.
patient.
Warre again. I have a
Yes,
question
sir.
for you. Have you seen
Yes,
any
sir.
case of developing leukemia after histiocytosis?
It is AML is, I mean,
Yeah.
can happen. So
We had a patient with AML after histiocytosis that we were transplanted. That's why I asked. So,
okay. We haven't had such a case yet, but yes, I mean, histiocyte disorders can lead to leukemia,
yeah,
especially AML. And
exactly. Yeah.
you're probably right. In those cases, probably they may be refractory to chemotherapy, and we may have to, yes. But for
Thank you.
LCH per se, I think there is
So
some
I
data, but
just came
not a
across a child in the OPD last week who was treated by hematopoietic stem cell transplant for a refractory CNS LCH. And the LCH part is okay, but there are sequelae of CNS involvement. And just so, Ramya, would you like to share your thoughts about the treatment plan that was taken up by the team at ICH? What Dr. Suganya? So, would you treat them on the same lines, or would there be any difference of opinion?
no, I think the same lines. I think they've done an amazing job with all those children. And the presentations were varied. And I think all three children had different courses and reactivations. And yeah, I don't think we would do any differently. But I think the question would be for the second case, which had the CNS disease, I think. They said they were on the sixth or fifth cycle of the, I think, cytarabine with vincristine. The point would be what maintenance to give after that, because whether they can stop after the sixth cycle and say, he's in remission, we'll keep on follow up, or should he be? So these are patients where there would be a role for giving maybe maintenance indomethacin or celecoxib and one of those kind of drugs, and
So,
more of anti-inflammatory.
yeah, we have a question on maintenance therapy in LCH post liver transplant, RRC versus 6MP.
I honestly have no experience with this, so I don't know what people are using.
I'm not sure. There would be some immunosuppression anyways going on after
Yeah.
liver
They
transplants.
will be on tacrolimus mostly.
Tacrolimus. I'm not sure whether I would like to
That may
think of adding
probably
on to some other thing.
no, don't.
Okay. So, Manas, any thoughts from you? And then we can wrap up today's session. I think Manas has left because he had asked for your comments on the cases. That was the last message, right? Thank you, everyone. Suganya, Dr. Malik, and Ramya. It was a pleasure having you here, and
Thank you.
frankly
Thank you,
telling,
ma'am.
we learned a lot today,
Thank
and
Thank you,
you.
Dr.
we'll
Shruti.
continue such sessions
Thank
again.
you. Thank you.
Thank
Thank you, everyone, for joining, and